This is an introduction to laparoscopic suturing. Laparoscopic suturing is one of the more difficult skills to learn, but once you have mastered that, you can pick up most other laparoscopic skills easily. I've borrowed most of this from another YouTube video, but added some bits and pieces here and there. A key difference that you will notice throughout will be the port placement and angles created with the instruments. Thanks, Dr. Wu, lovely suturing. Each different port placement has its advantages and disadvantages. It is not worth practicing skills in positions that you'll never be able to use in real life. Needle anatomy. This video uses a CT1 needle. It seems obvious, but you need to know your needles and request the appropriate needle and suture. The suture will need to be cut as well. You decide the length, and you live with the length that you get, which is probably the length that you asked for. Each needle has a tip, a body, and a hub, which is also called the swage. The needle is not the same along its entire length. This affects how it moves through the tissue and how you can grab and hold it. The swage is circular, but the body is flat on two sides. This allows it to be grasped more securely. You should try to grasp the needle at one of these 3 points only. This will make you more efficient. Point A is on the suture, 1 to 2 centimeters from the swage. Further away for bigger needles. Point B will be a point 1/3 from the tip of the needle. This is the fulcrum for rotation. Lastly, point 3 is a point 1/3 from the swage on the flat portion of the body of the needle where the needle driver grasps. Needle entrance. Grasp the suture at about point A. Most needles will fit through a 10 to 12 millimeter port without any problems. Not all 5 millimeter ports are the same. The port in this video is an XL port, which has a smaller internal diameter than the applied medical ports. Know your ports and what fits through them. When you start operating, if you're expecting to need to suture, think about that when you request the instruments that you're going to use. When working with a 5 millimeter port, you first place the instrument through the port, take the trocar out so it remains on the instrument, grasp the suture, and then place the instrument back into the patient. After that, you can slide the trocar back over the top. This is much harder on a human than on a model. If you're doing a hysterectomy, consider placing the needle through the vagina when you remove the specimen, especially if you're not using a 10 or 12 millimeter port. Handling. This is a skill that does not differ in a patient or a lap trainer. Practicing it will be very helpful, especially on the evening before or the morning of a case. Overall, try to make your life easy. Avoid randomly grasping the needle and suture. Try to get point A, B, or C pretty much every time. And you should only hold the needle at point C when you're planning to use it. In this position, it is stiff and will put a hole in anything it touches. If you're holding the camera, keep it in view, trust no one. Grasping the needle at point A and B allows you to swing the needle to get it into a good position. Both the left and the right hands can rotate to do that. Needle loading. When the light is reflecting along the whole needle, it will be perpendicular to the light source. If your instrument is also perpendicular to the light source and you grasp the needle, you will be grasping the needle at a right angle. In this video, they are using a Heaney needle holder. These have a curved edge, which can be beneficial. Traditionally, you grasp the needle so that the curve points away from the needle, not towards it, as is the case here. Check you're in the correct spot before you try to use it. Throwing a stitch. This should be the easy part. Set the conditions with good vision, appropriate instruments for you and your assistant, and the needle held properly. Close enough is not good enough and will cause you grief. Do it properly the first time. Aim to pierce the tissue, push straight, and then curve the needle. As it comes through the tissue, you will have to let go at some point. Try to consider point A when you do so you don't need to grasp and re-grasp over again. A maximum of 3 grasps should be the goal. Throwing a knot. Again, set the conditions for success. The ipsilateral port configuration is one of the hardest to tie sutures with. 5 millimeter ports are very low risk and inexpensive. If need be, put another one in. 5s are free. In the first demonstration, you will drop the needle. Create a long, elongated U with the suture. The angle the suture makes coming out of the needle holder is a key feature to intracorporeal suturing. When you create an acute angle, you can place your left instrument inside that U, then twist the suture thread round twice to create a surgeon's knot. Tighten the thread. Be careful not to pull on the short end or you'll run out of suture. Holding technique is often easier and useful when you do not have a lot of suture left. Grasp close to the end of the suture and rotate it. The best position is to normally have the needle in line with the suture and parallel to your other instrument. Try to keep the acute angle as well. Alternate your throws by placing your left instrument on the opposite sides of the suture when suturing. Other tips. Make sure the needle is in a good position. Practice before you start suturing. Suture in your U needs to be long enough and at an acute angle from the needle holder. If you're going to hold the needle to tie the knot, get it in a good position first. If you're having trouble, drop the needle. The tissue that it lands on can help to orientate you and create the 3 dimensions. If the universe sets you up for success, take it. Moving 2 instruments as a unit will make your actions more directed and efficient. It'll also stop you inadvertently catching the suture in the action of the grasper. Saying that keeping one instrument still whilst tying is easier than moving both hands.